Okay. So welcome to the DMICE conference. The summer conference, we have a couple at the end of the summer that are kind of special because we have an internship program that's funded by the National Library of Medicine. I'm David Dorr, the current PI of the program. Actually, our chair, Bill Hirsch, wrote the original grant and ran the program for most of its existence. And we're lucky enough to get a set of mostly undergraduate interns who get to learn a little bit about informatics and related disciplines. And then their most favorite part at the end of the summer is to present for the conference. So we'll have 3 presentations today, and I'll introduce the interns who are presenting. I'll actually introduce all of them because their mentors are going to listen to the live stream or listen to the YouTube but aren't here right now. So the first one is Mark. Mark is working with Melissa Haendel, who's an ontologist. Mark goes to school at the University of Southern California, where apparently you're majoring in computer science and business administration. Is that right? That's a nice one, with a minor in philosophy. So the way these are set up is he'll talk for about 15 minutes or so about his project that he worked on, get a little sense of what it's like to work in that area. And then there'll be about 5 minutes for questions. As always, please press down the buttons in the front if you're in the room so that the questions can be heard. And do we have somebody monitoring the feed, so in case there's questions that come over the feed?
Yeah, I will.
Okay. Our chair will...
They should tweet the hashtag.
Okay. You should teach... You should teach... You should tweet with the hashtag DMICE, D-M-I-C-E, CONF, C-O-N-F. All right? Great. So I'll let Mark go ahead and get started.
All right, great. So the title of my presentation is Visualizing Genetics. And so my summer internship was with the Monarch Initiative. And how many of you in this room have heard of the Monarch Initiative? Right, a good number. So Monarch Initiative has several goals. The main one that I felt like I was focusing on was like providing a portal for exploration of like phenotype-based similarity. And the Monarch Initiative basically wants to help bioresearchers better understand the genome and like phenotypes on the genome and how they relate to each other, especially like cross-species, is something my supervisor, Melissa Haendel, is a huge fan of. So like mice, how does their like phenotypic like diseases relate to human diseases, and zebrafish are the big ones that the Monarch Initiative works on. And I'll show you that later on. So phenotypes. Where are they on the genome, and like what correlations can we observe is the question that I was helping answering to researchers, and it's what the Monarch Initiative basically does. And phenotypes are basically anything that, how your genetics show themselves, like through hair or disease. We're mainly focusing on disease, so that's going to be the main example going through. So visualizing genetics, it could seem very simple because we have an actual picture of genetics, but you can't really tell a lot from there. Like you can't say, oh, right there is there's the gene that, correlates to cancer or to brown hair. But this is the highest quality picture we have of DNA, and it's pretty cool. So for humans, we like to say this is DNA, and that's how everything is sorted out. But also, that's kind of hard to label and say each part is the part that we're saying. So how can actual genomic and phenotypic data be conveyed visually? It's a very hard question, and a question reserved for biologists much better than I, being a computer science major. So luckily, the answer was given to me. And so this is from the University of, Pittsburgh State. And so they worked, and this is one of many examples that I was given. This is the one I like the most because there's some nice color coding going on with the phenotypes. The bands are pretty simple to understand. Like each one is a chromosome. And I'm a huge fan of colors, so I use this as my main inspiration for my project moving forward. And yeah, so the technology that I had to use to develop my project was, the main one was D3, which is a JavaScript library. It's a graphical library which helps you design and code fancy looking things, which for a visualizer is very nice. And then the base that I built off of was an Angular JavaScript, which is also a pretty advanced JavaScript library. jQuery, it's like pretty basic, pretty good. GitHub was where I pulled all the information from, was able to communicate and share my code with others. Skype was very helpful because the Monarch Initiative partners with a lot of different researchers in Berkeley and in San Diego, but not anymore, and in other places. And so Skyping and being able to communicate at any time during the day was very useful. And then a shout out to my favorite development IDEs like IntelliJ, the best one for sure, for JavaScript at least, and Java. So yeah, I will now show you what this was all about. So let's quickly look at the Monarch Initiative. So this is the main site, and as you can see, the main thing is like diseases described with phenotypes and gene variations associated with diseases. So the main focus of this is diseases and the phenotypes that they're related to, and different model organisms, and like the genes that they're plotted onto. And so as like researchers would go on and like want to look at different genes or like phenotypes and see where they are, there's like this graph, which is really cool and probably the best part of this website. But if you like go to a specific gene and wait for it to load, or we just did a new release, so there might be some bugs. Okay, let's try to go to a disease. So there's this disease that doesn't have any data with it. But anyway, all of it would just be what you're accustomed to seeing in the database, which is like letters and numbers, and all like really tailored to like a scientist who knows exactly what they're doing. And there's no real visualization that's easy to like compare with other things or see the cluster of it on the genome. And so since I was doing chromosome visualization, this is what other models look like. Like this is kind of an interactive one, and that would be very hard to dig through. And there's nothing there that would help you like graphically look and say, oh, yeah, I totally understand everything that's shown to me there. And so it was kind of hard to find like a base point to jump off of, but luckily there was this guy, Paul Parsons, and he had a pretty good chromosome visualizer based on Angular. And I'll show you that right now. So this is pretty much the chromosome number 1 of the human. And as you can see, like, it's very graphical. As you hover over it, like shows you the band name. And it's kind of easy to understand. And so this was a very good way, we thought, me and my supervisors, that this was a good way of representing the chromosome. And since this is all open source, I was able to pull from GitHub and base all my work off of like this chromosome band. And so my work would mostly be to take the data that the Monarch Initiative is collecting and collaborating with others of phenotypic data and to map it onto this chromosome. And so that's what I did, and I shall now show you the result. All right, here it is. So I'll start off with where I started. So I had this. I was able to take Paul Parsons' original code and just map out any chromosome I wanted to. The data that we were pulling, which is from Joffrey, and that's just like a bunch of all the features on the entire human genome is in that like database in the huge JSON. I was able to pull that, and it starts with chromosome 22, which is like for demo purposes, that's all I have displayed here. Because it's just like, it's easier to pull the very first ones from the JSON. So this is the band. The features are all the same. When you hover over it, it like gives you the ID of the band, and that's it. And so for demo purposes, I needed to pull independently, because at first it was easier to just draw them automatically, but there had to be more like user interaction, especially on the live, on the website. You'd need like users to select which variants they want or on what chromosome, so it would have to be dynamically pulled. So that's the purpose of this like field. So let's say we wanted 100, the first 100 variants on chromosome 22. There they are displayed, and so as you hover over them, it like tells you the type. That's right. So there's many types of phenotypes, and we didn't decide how we'd want to group them, and it had to be user-defined. So just as a proof of concept, I ordered them by the type of variant that they are, which is substitution, copy number, variation, sequence alteration, and insertions. So when you and those circles represent every single type. And so the first thing I did was I mapped a single one, like all general phenotypes, onto the center of the band. And then I made a color scale. So on this one where it's like almost a pink, there's one substitution. But then on the dark scarlet, you can see there's 18 substitutions. And so I designed a very simple, easy algorithm to make it so that no color is really too dark or too light, and it's always relative. Like if we were to pull 500, it's going to load. And this one still has the most, but it has 79 now, and this very light one has 4, but it's still visible, even though relative to 79, it's like so small. And so that's where I was, and then we needed to start displaying different types of variants, and as you can see, I was able to implement that as well. And so I was able to stack them as related to my first inspiration of the color-coded variants based on the phenotype that they represent being stacked on top of each other. And then I had to work on being able to remove some of them based on what the user would want. So I just did simple checkboxes. Once again, it's like a proof of concept. And so it automatically just changes. So there's no more substitutions listed. And then let's say we don't want to see copy number variations. We just want to see insertions. And there's only a few insertions. There's 1 there. There's 3 on this band. And moving on, I'd have to create a window for users if they wanted to just select one area. So if you click on a band, it selects that entire band. And then you're allowed to go in and like change the coordinates that you want. If I actually want it from 107, and then it goes like a little into the other band, and you can move it around graphically. And so I'd actually have to pull the data of all these different features, and that's displayed in this table down here. And this is a lot of scientific jargon, and we would be able, this was also, once again, just like as a proof of concept, I could easily make that more user-friendly and like describe exactly what the variant is in like layman's terms. And so it just has the ID, the variant label, and when you deselect substitutions, it gets updated in the table too. And so the table only displays the type that you select. So if I only have insertion, there's only 1 on that in that selection, so there's only 1 there, but there's 3 on this band, so now there's 3 in the table. And yeah, finally, we noticed that there were some features that span various bands, and bands are kind of an arbitrary form of measurement. And one of my supervisors, Nicole Washington, is a huge non-fan of them and constantly wanted me to be moving away from them. She didn't like that I constantly was centering it on the band, because she's like, bands mean nothing and scientifically doesn't matter at all. And so I had to display like when they move across, just so I could prove that I have that data. And so each one, the lines represent like when feature like spans multiple bands. And when you hover over, like, tells you there's one spanning there. And if you like click on that, it's going to select the entire. So that one feature spans that entire area and stops about like right before the next band. And so it's kind of cool. And so this was all done with D3. Of course, that's why it's so dynamic and so easy. It's a great JavaScript library. And then finally, scientists aren't a fan of horizontal bands. I don't know why. So what I was working on for the last few weeks is just to control everything and get it vertical. And I was able to do that, where it seamlessly is able to transition from horizontal to vertical view. And I was pretty proud of that. And it's much better now, because as you saw from the original example, all the bands were vertical. And it's just the way it's been done, and it's how people are used to visually seeing this. And so the whole point of this was just to make it more interactive, because the picture I showed you before is just a static representation of features and variants on chromosome. And this is much more interactive. And when this will be implemented on the Monarch Initiative website, it could be easily tailored to each person what they wanted to see on what region, and be very much easier to sort. And so moving on, what I'd have to mainly focus on is setting that the window would not be a predefined band, but in fact would be whatever the user would want it to be, like 50,000 DNA base pairs. And so then like each circle would be centered on like 50,000, and you could see which, and then when you click on there, it would zoom in to that 50,000 base pair, and then it like more lists out the variants. And I designed my code so it would be easier to build off of to later implement these things. And yeah, that's pretty much it, I think, of this. And so I'd finally like to say thank you to my main supervisor, Melissa Haendel. Then Nathan Dunn was also a great supervisor. He was the main computer scientist who I was doing a bunch of hackathons with on this. Then Nicole Washington down in Berkeley helped a lot with me being able to understand the biology behind it, because I'm not a biologist. And Kent Shevchek in the back helped me a lot. He was always there, most consistently one in the office. Matthew Brush helped. Jeremy Zwan and Seth Carbon helped a lot with Joffrey and pulling all the variant data and helping me understand the best way to do that. And they made a really good loader server that was really good. Shaheem is up in the office too, helped me a lot. Chris Conduit, unfortunately, has left the project, but he was incredible with supplying all the variant data that I was able to display. And so yeah, and there's yeah. That's it.
I noticed that when you're listing the features in that box below, there were a lot of them.
Yeah.
But the rendition only showed like one or two items. Was there ever a need to zoom in or zoom out on certain areas because there's a lot of detail packed in them?
I mean, there is a need. It wasn't that high on the priority list, so I didn't implement it yet. But yeah, you're right, because like, especially when I'm pulling 500, and this band is so densely populated, when I click on it, the table has like so much, and it's so hard to go through. And once again, as seen by like if I remove substitutions and copy number variations, it gets much smaller. I can easily like limit that down to what the user would want to see, and so it wouldn't be a problem to just quickly change it to have the person only see the variants that are related to a certain phenotype or a disease that he wanted to see, and only display that in a table. Because all the functionality is here. Because all this is like a proof of concept, and the concept is that I can easily alter what's displayed in the table based on what the user actually wants to see.
Paraschuk, and that's part of that. Could you speak a little bit?
Yeah. So as stated earlier, there were like Seth and Juan. They made this. Forget that. Oh yeah, that's right. The Golar Server Manager, and pretty much it's a very nice way of. It's made to work with the Golar data set that we're pulling, and all that. It is a huge JSON. It has like 255, 100,000 different features, and has all the chromosome band data, all the variants, every feature that is on the human genome. And so it is so large, but because of the server that they created for pulling data, it's much easier. It's one big JSON, so there is no perfect way to be able to go in. But the way they did it is you're allowed to like query special queries, which I could show you on my computer. But in the code, when I set a query, right now, how I was doing is I do like star colon star, which is the entire JSON. If I do like star and then I forget the certain ID number, it's only going to give me like bands and no other types of features. And so then I could like pull the bands and draw every chromosome that I would need without looping through the entire thing. And so there's this server that like makes querying very easy to get exactly what I want on where I want it. And so moving forward, like when a user wouldn't want to be on chromosome 22 and having all the features displayed, I could just set a different set of queries that he could then query and have that displayed for the user.
So now we're going to hear from Nick. Nick is a junior just finished his junior year, going into his senior year at Reed College here in Portland. He's majoring in economics and mathematics, and so this I really, since informatics is very cross-disciplinary, and a lot of our work, including my work, touches on sort of how data, information, and knowledge flows through the healthcare system and how that might influence health reform and the feedback loop in there. He's actually working with the Center for Health System Effectiveness with John McConnell and Peter Graven and others. Some of you are in the room now, looking at some more health economics type of studies. So I think this will be very interesting. Thank you, Nick.
Pull this up. Thank you, everyone, for coming today. And so, like Dave was beginning to talk about, a lot of the work that I have done with CHSC this summer has been kind of looking broadly at health systems, and in particular, John, my mentor, has done a lot of work to study the coordinated care organizations in Oregon and sort of track a number of things about them, and a particular feature of the coordinated care organizations in the kind of broader spectrum of healthcare reform is ways in which the coordinated care organizations can provide alternative or different payment mechanisms and what sort of payment reform looks like. So we're going to be talking about some kind of nitty-gritties of that in financing of the healthcare system in general today. So before I kind of get into that, some kind of just broad context of first healthcare spending in the United States. So in 2013, the United States spent $2.9 trillion on healthcare. That number is only bigger for 2014. It's projected to continue to grow. That's roughly 17.4% of gross domestic product, which is kind of the sum total of all things that are bought and sold in an economy in the given year. So truly a tremendous amount of kind of what makes up the U.S. economy. This graphic shows you, from the Congressional Budget Office, what some of the spending looks like for the government and the revenues that we get in through taxes. For those of you who are with us to see the interns, I think mostly John's presentation, this is that same graphic from there. You can see in 2008, government spending goes up as part of the stimulus bill and the bailout there. And you can see the CBO, Congressional Budget Office, projections going out into the future. That gap between the amount the government is spending and the amount we take in revenues is kind of only increasing over time. So nationally, healthcare spending is a really big deal. We should probably try and think of ways to deal with this issue. Looking a little bit more locally at healthcare spending in Oregon. So Oregon spent about $8 billion in 2013 on healthcare, which is approximately 20% of the budget. To give you some idea of other things Oregon is spending on, 26% of the budget goes towards education. So this is something that you can see is also projected to grow and is kind of of concern here in Oregon and other states as well. This is very much, you see this sort of trend of increased healthcare costs and spending going into it and not having clear ways to kind of drive down those costs.
That's the state spending on healthcare, the state of Oregon, not the population of Oregon.
Yes, correct. Yeah, this is the state itself. Yeah, you're absolutely correct. So again, similar sort of graphic you can see of our expenditures increasing above our revenues, that band increasing over time for Oregon. And so there's kind of this broad and perhaps intuitive and immediate question, which is what do we do about the rising healthcare costs in the U.S.? How do we manage this better? At the federal level, we see huge reforms like the Affordable Care Act as well as the Patient Protection Act that have kind of dominated a lot of news even recently this summer, but certainly at different points in time. But I think kind of a lesser known side of healthcare that you begin to be a little bit more aware of when you find yourselves embedded in health systems or doing health systems research is that the Center for Medicare and Medicaid also regularly and has in the past and is currently approved of a number of state demonstrations. So these are essentially agreements where CMS says, all right, we are going to allow you to do some sort of new experiment, new innovation, or new idea for handling the healthcare system for your Medicaid or Medicare populations. And part of what you get in order to do this kind of new unconventional thing is you have to promise us that you're able to expand coverage to people and while maintaining quality. And so currently there are a number of state demonstrations for accountable care organizations. So accountable care organizations, we are putting this kind of in the terms of economic theory, are a supply side policy lever. So that is to say these are care organizations that we make that presumably have certain goals, metrics, and defined ways in which they interact with their patient populations. In sort of like managed care organizations, but with kind of more oversight from communities, governments, regulators. And the reason I bring this up is a supply-side policy lever is this is a little bit different than demand-side reforms, where we would be doing things like experimenting with co-payments for individuals in the Medicaid population. So these are typically low-income individuals or vulnerable communities in the first place. The kind of historic reasoning behind Medicaid is that these individuals wouldn't pay co-payments because they're sort of not able to in the first place, or that might strain their access to care in some way. However, there are some states that are saying maybe we introduce types of co-payment structures for those individuals to see if that can affect our healthcare costs. This is something much different in going straight to health providers and saying you need to begin thinking about integrating your care systems and coordinating in new ways that you maybe haven't before, and that there are costs to be saved by doing that. So that's sort of what affordable care organizations are doing at the large. And even drilling down a little bit more specifically into what's really in general behind this sort of supply side reform, and it's a transformation of both the delivery system of healthcare as well as the payment system, which I'm going to be focusing on the second of those latter. But this is things like not only are we talking about different ways in which we ensure that patients have access to their healthcare providers, but what are the ways that healthcare providers coordinate amongst themselves, amongst insurance companies, so on and so forth, to actually determine how you are paid for the medical services that you render. And so currently the sort of predominant model that you see in many places in the United States is this sort of fee-for-service model. And that's to say that there is some unit of healthcare service, or there's a particular thing that you need, and then someone is billed or reimbursed for that. I go into the doctor and I say I have chest pains. The doctor says, all right, we're going to run these 3 diagnostic tests. At the end of the day, the health insurance provider, be it Medicare, Medicaid, my employer-sponsored insurance, is going to reimburse that individual for the services they rendered. But as you can maybe begin to extrapolate from this, there's no clear incentive in that sort of world or environment to try and keep people healthy in the long term. Sort of in layman's terms, if you're getting paid every time you do a medical service, presumably your goal would be to do as many medical services as possible so you can get paid the most. That said, it's also worth mentioning that when we talk about how healthcare providers interact with insurance companies, it's really relatively easy to configure payment systems. That's to say, it's easy to track and count exactly what happened, because you just have a bill that says you came in, these 4 things were done, and we need to pay someone for those 4 things, which it will be a little bit important later on. So this graphic sort of describes different ways in which we could think about conceivably spending on healthcare. So currently we find ourselves in this green box where you have some unit of service, you're reimbursed for that unit of service. But because there isn't much incentive in that payment structure to make sure that individuals are healthy in the long term, or that we're providing the most efficient or value-based or outcome-based care, we want to try and think of other realms or types of payments that we could move towards. And so the goal is that we try and move to these sorts of global payments, and that's something that Oregon has been trying to move towards in our healthcare reform. And so coordinated care organizations, the CCOs, which you might have heard about or heard a lot about, you have heard none about, some amount, are kind of Oregon's brand of accountable care organizations. So all of them are community-based and kind of decided and created based on communities and regions. They have governing boards that bring together all sorts of different stakeholders. They are accountable to the state of Oregon, as well as the Centers for Medicare and Medicaid, to perform on a number of measures of health outcomes that have been identified as outcomes that are important to make sure they are maintaining a sort of quality of care, whether it be the same quality of care as before or improvement in those areas. And their goal really is these last 2 things: to integrate the delivery system by integrating our physical, behavioral, and oral health, and also to be paying healthcare providers through a global budget, or making sort of global payments, which is the end of that box on that last side. And so this scale of this, I want to give a little bit of weight to it. So the federal government's invested almost $2 billion over the course of the next 5 years, and the state of Oregon has said we're going to be able to return your investment by that, because of all the savings that we are going to be able to generate from our healthcare system. And then we also further agreed that we're going to lower the medical trend by 2 percentage points. So this is something that when you talk about state waivers and new demonstrations, the scale and magnitude of what's going on in Oregon healthcare reform really is revolutionary. I would perhaps not go quite so far as to say historic, but it's to say that these innovations are definitely new compared to what we've seen for types of ways that states have tried to reform their healthcare systems. So kind of focusing on that second real target of the CCOs, which is the global budget and coordinated care organizations. So coordinated care organizations are giving capitation payments from this kind of global budget that the states have on a per member, per month basis. And what that means is the state has this large pool of money for Medicare, Medicaid. Some of it is the state's money, and then it is matched by the federal government. And we say, all right, coordinated care organization X, we are going to give you X amount of dollars based on your underlying patient population. And then the states pay coordinated care organizations who pay out their healthcare providers from there. The idea for this is this shifts the risk, the financial risk, onto coordinated care organizations. You know, healthcare providers, if they go over in terms of the amount of costs they're being paid, they are the ones that have to assume that now. Or if they come up with losses, it is because they're the ones who did not manage care a particular way. So this is an attempt to try and get away from that fee-for-service world where there is no incentive to keep patients healthy in the long run. But a thing you might ask yourself is, what is a fair price for some bundle of patients or some patient population, accounting for the potential healthcare risks and needs that they all might have? To me, that sounds very complicated, and that's why actuaries are the ones at the Oregon Health Authority who try and come up with what that payment rate looks like based on things like underlying population characteristics, treatment costs, operating costs, health risks, risks from uncertainty in terms of the modeling and projections they themselves come up with, and kind of a number of other things. So, the kind of the agent that we're interested in now is how is it actuaries do this, and what's a fair price for an average patient in some population? And so then this issue of how exactly do we have an actuarial rate setting methodology and one that is fair? Kind of first, and moreover, what is the issue of actuarial soundness? I promise we're getting close to the punchline. And so a lot of that kind of first question was introduced through the Balanced Budget Act of 1997, which said that capitation rates, these kind of bundled payments for managed care organizations, have to ensure that patients have some sufficient access to your care. You can't say that a patient that is high risk is going to cost some tremendous amount and therefore could be excluded from your pool. And that is precisely one of the reasons why the Balanced Budget Act was implemented, to try and deal with this issue of managed care organizations setting seemingly arbitrary rates or setting rates that seemed unfair to provide health access to the patients in their populations. And so the precise language of actuarial soundness of the Balanced Budget Act says that capitation rates must be developed in accordance with generally accepted actuarial principles and practices appropriate for the populations to be covered and the services furnished, and certified as meeting applicable regulatory requirements by qualified actuaries. I don't know about you, but when I read that, it doesn't really mean much to me, and it doesn't really seem to be saying much of anything. And in fact, that was sort of also the feeling of CMS when the Balanced Budget Act came out. So they requested to the American Academy of Actuaries that there has to be some sort of rule that we actually go about saying this, because the new federal law just said actuaries are going to come up with rules and best guidelines to conform to regulations, to which the American Academy of Actuaries said that some general kind of ideas for how managed care organizations set their capitation rates should be based on historic cost and utilization data. In order to get a good projection, you should have a pretty good idea of what's been happening in the past, and that you should somehow use that information to ensure that subsequent rates are going to be able to provide sufficient access of care to your patient populations, like the Balanced Budget Act wants you to. Initially, though, these guidelines are non-binding, and the American Academy of Actuaries was clear to emphasize multiple points in their practice note that there may be some alternative methods or different rate-setting methodologies that could be appropriate for this aim, and that individuals should feel inclined to try and use those if they think they're going to be more efficient for their patient populations. And so what Oregon was doing starting in 2011 and having coordinated care organizations use was a thing called the cost template. And it's one of these examples of a sort of alternate method where we would use capitation rates based on this. And this sort of cost template asked CCOs to report administrative costs, financial costs, generally the costs and encounters of different things happening in their patient population. The Oregon Health Authority's actuaries would look at it, kind of squint, and say, this seems to be valid, or you were more or less on track. More importantly, though, is in 2011, there's a cap spent set in aggregate for coordinated care organizations for how much they could be increasing their health costs by, and that was set at 3.4%. Magically, so that Oregon could hit the target that we said we were going to hit with the federal government, so that we didn't owe them a lot of money at the end of our 5-year demonstration to them. So then, in 2015, and even prior to that, CMS had some problems in other states with actuarial standards just not being followed through. The Government Accountability Office and the Department of Justice even were getting ready to say, CMS, you have this actuarial soundness rule, but you're not really consistent in how you apply it across states, and you need to have a more granular examination of what states are actually doing for their capitation rates. So taking cue from this, CMS said to the state of Oregon that in 2014 that the cost template is not in compliance with this, and in response they also created managed care capitation rate setting guidelines that were now binding. So before, their practice note said, we would think that you should be considering these sorts of things in coming up with a capitation rate. Now that has shifted to say, you must be doing these sorts of things in order to be setting actuarially sound capitation rates that are in compliance with federal law. So like I said, CMS was a little bit displeased with the idea of the cost template and told the Oregon Health Authority about that, saying that they had concerns over the endemic shortcomings in Oregon's rate-setting methodology from 2011 to 2014. So this is quite a big criticism to be levying against the state of Oregon. There were some smaller problems that they brought up in that letter, mostly related to some unfounded expectations about the expansion population. In general, the Centers for Medicare and Medicaid said, you just seem to have overestimated a number of things, and we can't really find the assumptions you've made for 2014, and these numbers just look a little high to us for capitation rates, is more or less the substance of these smaller problems. But the large problems, and the ones that are in fact kind of still in question and in dialogue in the state of Oregon, are about the lack of encounter data that the state has submitted and the lack of granularity in that encounter data, as well as various unclear assumptions about how Oregon was actually setting these rates, what methodologies they were using, and how they were calculating capitation rates for coordinated care organizations. Oregon Health Authority readily amended some of these smaller issues, and in order to begin to deal with these endemic shortcomings that the federal government, through CMS, found with how coordinated care organizations were setting their capitation rates, they said, okay, for 2015, we're just going to throw out the cost template. It's been deemed actuarially sound. We're not going to argue for it. So we're just going to throw that out and try a new methodology for 2015 that's more rigorous. The Oregon Health Authority went so far as to hire Optumas, which is an actuarial firm, to verify all CCO data in coordination with the Oregon Health Authority. And the Optumas also created an entirely kind of new portal and methodology for the data verification from coordinated care organizations, and then applied this from the 2013 data moving forward from encounters that occurred in order to calculate the 2015 rate. So in a lot of ways, it kind of, getting some of the policy language out of this. This is really to say, for 2015, the Oregon Health Authority threw out the playbook that they'd been using for how CCOs were reporting their costs and getting paid from the state, and decided they really have to kind of start from square one in a way that is in accordance with the CMS regulations if they're going to continue to kind of move forward with healthcare reform and with payment reform. So now, like I said, that sort of financial report and that data verification procedure happens because CCOs have to, in 2015, submit their data both quarterly and monthly across things like cost, utilization, administration, and these other specific financial costs, like how much cost they've incurred, accrued, as well as sub-capitation rates, incentive payments, alternative payments, all of that kind of more jargon. But the real idea here, I think, is this new data verification process that Optumas and the Oregon Health Authority came up with together now basically requires every month and every quarter coordinated care organizations to be reporting a lot of data to them about basically their entire financial profile in order to solve this problem of having endemic shortcomings in the sort of data we submit to the federal government. And so this is kind of now the area in the realm we find ourselves in, but there's a number of health policy questions that I think are remaining not just for 2016, but also for Oregon's kind of attempt at healthcare reform moving forward. I think kind of the most obvious question is if the reason that we wanted to be using global payments and we wanted to be, and one of the reasons we created these coordinated care organizations was to get away from the fee-for-service world. Are we still able to do that in a system that the federal government mandates we have to do with this degree of intensity in the financial reporting? Is there still room for coordinated care organizations to be engaging in the sort of flexible spending or spending based on value or outcomes that they originally set out to do? And so, so I think this, to me, is still lingering, and it's something that we're only going to kind of be able to see moving forward. Some potential solutions could be that the CMS could offer some sort of amendment to Oregon's waiver. Doesn't seem unlikely and seems that more likely than not that would break some federal reporting standards and kind of violate the law, the actuarial soundness standard. So it's there's probably not some political compromise between the two bodies that we could see. Another solution is that we come up with some sort of new rate-setting methodology that solves this problem or allows for more flexible spending in coordinated care organizations. But a big problem is that actuarial world kind of moves slowly. It would seem difficult to come up with an entirely new rate-setting methodology within the course of a year. And sort of where I personally feel the issue kind of ends, and what I'm curious to see with it moving forward is, I think that this kind of financial submission puts us in alignment with federal rules and regulations, and that there's just going to have to be some sort of awkward transition from a fee-for-service world into using this extensively reported financial data for calculating, setting, and reporting capitation rates, and that there's just going to have to be some kind of growing pains that CCOs go through. Sort of the negative spin on it. The positive spin, though, is when we talk about maybe scaling up accountable care organizations for not just Oregon, but other places, we maybe learned that there's a sort of workflow to implement them well in terms of first making relationships and information channels, transitioning that into how we improve our delivery system and coordinate our care and better ensure quality. And then from there, once we scale our successful strategies, it might only be at that point that we just have the administrative time, money, and energy to begin approaching things like developing a very robust financial reporting system for coordinated care organizations and other care organizations to report things so that they can come up with capitation rates and get us out of the fee-for-service world. So yeah, that is some of what I've been working on. Yeah.
We have maybe time for one question.
Yeah.
this endemic problem, what is it that those rates are?
Oh, I have to hold it up.
Yeah.
Is it that they think that the budget is just wrong, like it's too high, it's too low? Do you think that one CCO has too much given their population versus the other one? I mean, in some ways, that I think would imply is looking at 2016. It would be interesting to see how their spending changes as they adopt the new. So I was wondering what your thoughts are.
Yeah, so it's all of it, right? CMS's concern is that when you look at the CCO data and then the data that OHA on the CCOs is submitting to CMS, you find discrepancies there in terms of rates or in terms of how you would calculate rates. So part of it is that. I think the concern is not just are we overpaying CCOs, but it's how are we deciding how we pay CCOs, and is it consistent and isn't transparent? And CMS seems to be saying it's not consistent or transparent, and it's too much uncertainty for us to comfortably say that this is an okay practice that you have going on.
All right, our final speaker is works with me, Dave Dorr. So as he puts on his microphone, Steve is also just finished his junior year, going to go into his senior year at University of Connecticut. And he's actually very interested in going on and to graduate school in epidemiology. So has actually spent some of his time sort of going around and talking to different schools about future programs. So obviously I'm very fond of his topic here since it's my research area.
Thank you, Dr. Dorr, for that introduction. My name is Stephen Roncaioli, and for my presentation, I will be talking to you about risk stratification for patients with multiple chronic conditions. So unfortunately, this slide's kind of useless. Dr. Dorr kind of explained that already. No, it's fine. Don't worry about it. No, don't worry about it. So a brief overview of my presentation. I will start with explaining why risk stratification is important. I will then go into a brief introduction on the project that I worked on this summer, which is multiple chronic conditions, or MCC for short. I will then talk to you about my specific contribution to this project, as well as results, important findings, and conclusions that I was able to draw. Last, I will touch on some of the next steps for the project. First and foremost, why is risk stratification important? Risk stratification is defined as the process of taking patients and distributing them into different categories based on their perceived risk for future negative outcomes. So as you can see in this diagram here, we have a group of patients, and it's the job of risk stratification to distribute them into different groups based on their risks. So in this picture, we use different colors to demonstrate that risk, with red obviously being a patient who's high risk, while green would be more of low risk. The issue in today's society is that doctors are very good at looking at a patient who's showing certain symptoms and diagnosing them with a specific disease, and then providing them the proper medication for treatment. However, many doctors fail at looking at a patient and saying, I believe that in the next year that this patient will have a serious negative outcome, or I believe that this patient will be relatively healthy. So through the process of risk stratification, we would be able to properly identify these people. It's especially difficult for doctors to identify patients with multiple chronic conditions, as these patients are usually seeing many different doctors, and there's usually a lack of communication between the doctors. So there are usually issues in terms of the treatments that they're receiving and their overall treatments. So one important fact I want to point out to you is that on average, out of all the patients who seek medical care, 5% of them will account for nearly half of all medical expenditures. So through risk stratification, we could potentially solve this problem, because if we can identify which patients will be costing the healthcare system the most money, we can target them through care management practices in order to try to mitigate these risks. Examples of care management practices would be having a care manager be assigned to a patient and giving them a specific treatment where they would be following their medications and making sure there's strong communication between the different doctors that they're seeing. In theory, if we could risk stratify them and apply proper care management, we would be able to reduce the costs through the healthcare system. an introduction to my project, which was multiple chronic conditions, or MCC, first it's important to point out that risk stratification is not a new phenomenon and that it's actually been around for a while. However, MCC is unique in the sense that it attempts to use EHR data for risk stratification. Many previous studies have looked at the use of, many previous studies have looked at the use of claims data in terms of using risk stratification, and the process for that would be taking patients' records for the past year, adding up all of their costs, and then determining which patients have cost them the most money, and then the insurers would target these patients and try to reduce their future costs. However, there's a lag time of about 18 months for this to occur, and that's a large time gap where if we could use EHR data, which is constantly evolving and it's always present, we could risk stratify our patients a lot faster and then possibly even treat them during that 18-month period and possibly prevent some of the outcomes that could have occurred. So the objective of the MCC project was to understand if we could use EHR data to improve the risk score prediction of patients. Right here we have a picture of a screenshot from the EPIC EHR, which is where we pulled most of our data from. And the three sources that we used for the risk score predictions were the problem list, encounter, medical history, and then a combination of all three of those sources. For problem list and medical history, they're very similar in the sense that it's a place where any doctor can write down issues that the patient was having. However, problem list is supposed to be more pertinent to what's actually going on with the patient right now, while medical history, as the name would imply, is supposed to be history, so issues that are not currently affecting the patient, but they were in the past. However, many doctors do not follow these standards, and it ends up that both the problem list and medical history will have information on patients' conditions, whether they are currently affecting them or if they're in the past. Encounter, on the other hand, is an EHR source that is supposed to be more relevant in terms of predicting patient outcomes. The encounter source is linked to a specific instance where a patient visits a clinician and they are treated for a specific condition. So in the encounter source, you would have a documentation of when a patient visited a clinic, for example, for a complication with diabetes, and there would be a documentation saying that this patient was treated for their diabetes, and that would be a more relevant example as to an issue that the patient might be having later on. For a brief overview of the experimental design for MCC, we started by reaching out to primary care clinics throughout Oregon, and those practices that were willing to work with us for the study, we extracted EHR data for patient-level data on their medical history as well as current conditions that they had. The three risk score algorithms that we use to create the risk scores are listed here. We have the modified Charleston comorbidity index, which pulls ICD-9 codes out of the EHR. We have the hierarchical condition categories, or HCC, which was developed by Medicare and Medicaid, and then the Affordable Care Act qualified conditions, which is unique in the sense that it also incorporates mental health conditions, and it was enrolled by the Affordable Care Act a few years ago. It's important to note that the risk score algorithms are pulling data from the baseline year of the patients as well as previous medical history, and that the risk scores that they are providing are for the predicted year, which is a one-year period after the baseline period. The outcomes that we were looking at for this experiment were hospital visits, ED visits, cost, and length of stay. However, for my particular project, I did not look at length of stay, just the other three. So for my particular project within MCC, it was my task to create a data visualization to try to figure out if the risk score predictions were actually predicting what they were supposed to. Because at the time that I got onto this project, we had yet to run any multivariate analyses to actually determine the statistical significance of the results. So I created an intermediary where we'd be able to quickly analyze the risk scores and try to see if they were predicting what they were supposed to. So this diagram that I threw together here accurately portrays my journey to the end product. I had a very large data set that had information on patients' baseline and prediction year risk scores for 4,112 patients. And I started with using a pivot table, which I have here. And this was a feature in Excel that I had never used before. However, it was very intuitive, and it ended up saving me a lot of time in terms of graphing the data and getting the things that I wanted to show. This middle picture is a very good representation of some of the struggles and frustrations I had along the way. Excel was very difficult in terms of formatting the data and modifying it in the ways that I wanted to. So there was a lot of trial and error for that, but I ended up coming up with these graphs here. This is one of 36 that I ended up making, and I'm fairly content with how they turned out, and I feel like they're a very good way to represent the data. So how you would interpret this data, or the graph, on the x-axis you have the different risk scores that the patients were given through the algorithms. On the primary x-axis you have the different, or you have patient count, so the number of patients who were given each risk score. And then on the secondary y-axis you have the rate of the outcomes, and in this case you have the rate of ED visits. So if you wanted to interpret this graph, you would look and see, if you look at the pivot table, if you were given the risk score of 0, you have less than a 0.5 rate of average ED visits. However, if you were given a risk score of greater than 5, your rate of ED visits jumps to over 2. So you would say that from having a risk score of 0 to a risk score of greater than 5, that there is a 4-fold increase in the rate of ED visits. One important thing to point out would be that a majority of the patients will fall in the low risk score range, so that's why you have very high bars for the low risk scores, and there's a very small amount of patients in the upper bins. And this goes hand in hand with what I mentioned earlier, with about 5% of the patients accounting for most of the outcomes. Also, real briefly, the general hypothesis that we had for these graphs would be that as the risk scores increase, so would the average rate of the outcomes. This is an example of one of the tables that I created, which this is one of 3, and they will be going into the outcomes paper that will be getting published later on. And this particular table is looking at hospitalization outcomes. So it's organized in the sense that you can look through the columns, and it's organized by the different EHR sources that we pulled the data from. And then the rows represent the different risk score algorithms that were used to generate the risk scores. One neat thing about these tables is that all the axes are standardized, so it makes it very easy to look down the columns or across the rows to see general trends amongst the different scores. As you can see here, there are error bars for each of the different points along the line graph, and these represent the 95% confidence interval for the standard error of the mean. Also, one issue that I was having in terms of creating these graphs, as I mentioned before, a majority of the patients will be in the upper risk score ranges, so when you got into the higher risk scores, there would be examples where a certain risk score would only yield 3 patients with that risk score, and if there were any outliers in that sample set of 3, it would drastically affect the general trend of the line. So I chosen the number of 30 as the smallest sample size that any risk score could have. So with a larger sample size, it was a better generalization of the trend line. For important findings and conclusions, I'm not going to take the time to go through all 36 of the graphs that I made, so I highlighted a few trends I wanted to point out. These 3 graphs here are from the problem list EHR source, and they are looking at the rate of hospital visits. This is an example of some good results. As you can see, there's a steady upward trend. So as the risk scores are increasing, so do the rates of the hospital visits. Also, it's important to point out that if you look at the upper risk score ranges, the error bars are relatively small. So there's minor variability in those results, which will end up not being the case later on. It ended up turning out that the problem list EHR source performed the best in terms of the different EHR sources for the prediction of hospital visits. I believe that this is the case because, as I mentioned earlier, problem lists should contain specifically problems that are currently affecting the patient, but however, they could also have instances of conditions that might not be affecting the patient at that time. So that would be pretty indicative of patients with multiple chronic conditions, as they could have an issue later on that could spur a hospital visit. Next, these are 4 graphs from the Modified Charleston Comorbidity Index, and these are predicting ED visits. So this is an example of some poor results, as there's a flat trend line across the board. So as the risk scores are increasing, the rate of the ED visits is remaining relatively constant. And this goes against our hypothesis because we predicted that the rate should increase over the increase of risk scores. And the reasoning behind this is actually because when the Charleston Comorbidity Score was modified, it was reweighted to predict hospital visits as opposed to ED visits. So if you go back and look at this table here, which shows all the different outcomes for hospital visits, the top the top row is for all of the different EHR sources for the modified Charleston score. And you can see that it actually performs relatively well for hospital visits, which is supposed to do. Lastly, I've chosen two graphs from the hierarchical conditions categories, risk score algorithm, and they're predicting cost. So at quick glance, you can see that these graphs are, or that these outcomes are pretty good, in the sense that as the risk score is increasing, so does the cost. And on average, there's about a 4-fold increase in the rate of cost as you go from a risk score of 0 to a risk score of greater than 3.5. However, if you look at these upper risk score bins, you can see that the error bars are very hot, very large, and there's high variability amongst the results. So it makes it difficult to draw any accurate conclusions. However, the HCC risk score did actually perform the best in terms of predicting cost, and I believe that this is the case because it was actually developed by Medicare and Medicaid strictly to predict average cost for future patients. So it makes sense that it performed the best in this sense. Now I'd like to talk about some of the next steps for the project. As I already mentioned, sorry, Dave, for that picture. As I already mentioned, we have yet to run any statistical analyses to determine actually which risk scores are performing the best or which EHR sources are best to pull from. So the next step would be to analyze and interpret these results to figure out which is the best. And actually, Dr. Dorr's team was awarded a grant recently, which I've listed here at the bottom, Improving Implementation of Risk Prediction in Primary Care. And the goal of this grant is to incorporate the findings that we've learned from MCC and then implement them within primary care clinics throughout Oregon to try to improve their risk stratification methods. Another aspect that we'd like to incorporate would be to add a clinical intuition to the risk scores. So by adding a human perspective of a doctor as well as the computer-based risk score algorithm, it would create a more representative risk score. And with that, I would like to once again thank Dr. David Dorr for giving me this opportunity to come all the way from Connecticut to Portland. It's been a great opportunity for me, and I've learned a lot of valuable skills that I'll be able to use later on in my academic career. I would like to thank the CMP team, Bhavya, Tracy, Raja, Jesse, Shelby, Lindsay, and Doug for your support throughout the summer and providing me with plenty of tasks to keep me busy, as well as the rest of the MCC team for assisting me with any questions I had throughout my project. I would like to give a special thanks to Ben Neely, my cubicle buddy. We spent a lot of long office hours together, and he definitely kept me sane throughout that time. And I'd also like to thank the rest of my fellow DMICE interns. And with that, I would like to open it up to comments and questions. Thank you. Yeah.
In your display of the 9 or so figures, what's going on when the curve starts to go down at the end?
So I've touched on this before. So when you had the higher risk scores, you'd have a small amount of patients. So if one patient had a risk score outcome that through the data it didn't provide the best results, it would easily skew the trend because there was such a small sample size. So I try to combat. This is better results than what I had originally. So what I tried to do was combine some of the risk scores. So you can't see it here, but if you look at some of the other ones, you can see that it says that the risk score is greater than 2.5. So there are other risk scores that we had, but I just combined those together to have a larger sample size. And then that did a better job at trying to balance out the trends. But there are still instances where it would dip down at the end.
There's another part to that, which is that there's no indication that these risk scores are linear, and there's an implied linearity by sort of graphing them out in this way. Their characteristics are really weird, basically, and so we see a lot of this moving around like this.
Thank you. So you started this saying, essentially, we want to try to predict the 5%. But that problem is the 5%, it cost us 50%.
Yes.
I read your graphs as doing a good job predicting who is in the low versus the medium. And I was just kind of trying to get your thought on this. Is that a value as well? Is it something we might want to, because, right, even in the good cases, your standard errors are huge. right? And I mean, your mean happens to be up, so you find upwards trend, right? But your 95% confidence interval often is, sure, it could go down. There's really no way. Lots of ways where it could go, right? So kind of it seems more robust in this low and middle category.
Yeah, so obviously with a larger sample size, it was a lot easier to get more confidence in terms of the lower risk scores. And that was one of the challenges with creating these upper risk score ranges, because that's what we're trying to predict. And Dr. Dorr can touch on this a little bit better, but the current risk score prediction algorithms that are out on the market today aren't actually that great at predicting. So even though we have a lot of errors here, these preliminary results are actually fairly good in terms of giving us a general sense of what this upper 5% actually represents.
Low risk scores versus medium as a cutoff. So the next step people will do, which is implied by these graphs, is cut off at 5% and say, I've got a resource like a care manager that can only address 5% of the patient. Which 5% should I have them work on? And so that's why we so focus on that. But there's other groups like transitions of care people who say, oh, for all the hospitalized patients, I actually want to know the bottom third that will never have a readmission. And so that good performance here, they would just love, because they'd say, oh my gosh, yeah, I could really tell there's this inflection as they go from very low scores up. And that'll be great, because then I can sort of look at that two-thirds more in depth, maybe do some more risk analysis on them, because they're physically within the clinic still, whereas in primary care you really don't have that, or in the hospital still. In primary care, they're gone, so you just use the information you have. So that's really probably the difference in why we have this very high cutoff, because we have to figure out which 5% that we allocate these resources to.
Any other questions? Yes.
With respect to medical history.
The EHR source? Medical history EHR source? Okay.
So do you have statistics, or can you give us a feel for kind of the duration of medical history, how consistent that was amongst the patients?
So I don't have any particular information in terms of the actual EHR sources and what we pulled. I just had the risk scores. However, the medical history EHR source pulled from years back. I think we had about 5 or 6 years of data from back, and we pulled all of the conditions that were listed in the medical history list from that time period. So it's a fairly good representation of the history of the patients, but I'm not exactly positive with that.
Again, one of the next steps is to add temporality, actually, to it, but these risk scores don't allow for it. So Aaron Cohen and Matt, I forgot his last name. What? Thundlin are actually sort of recalculating these, adding with two hypotheses. One is very recent history might be really more valuable, and one is very old history might be more valuable depending on the condition. So they're really decomposing it and doing some machine learning techniques to see if they can predict, add features and predict better. Just wasn't able to do it with this.
Thank you.